I'm the course director for this series. We are glad you are joining us as we resume this monthly geriatrics echoes after several months of hiatus. So next slide. Okay, so this is basically a forum, right, for mutual teaching and learning from experts and from each other. And so the ECHO motto is everyone teach, everyone learn. And so we want to create a community of learning. And so we really encourage you to participate, ask questions, and don't be shy. Okay, so so basically the format is a short lecture from an expert, expertise from our team, and then open up for case discussions. We actually invite you to share any geriatric cases, even it may or may not be related to today's topic, in case you have questions about geriatrics. And we're really willing to share our collective wisdom and knowledge with you. The only thing is that we should keep it HIPAA compliant. Next slide. So this is, we commit to maintain and safeguard confidentiality of information. So we have, all case presentations have to be de-identified and HIPAA compliant. We want to create a safe learning environment and foster a culture of mutual learning and encouragement, so no negativity or anything like that. These case consultations do not create or otherwise establish provider-patient relationships between any echo specialists and the patients that you are talking about. Next slide. This is our calendar coming up. We are right now in December, and we have Dr. Brett Liu here joining us for that. I'll do an introduction in a bit. Next month, we're going to be doing falls assessment, and after that, we'll do some advanced care planning. So we have a nice lineup coming up for the spring. Next slide. Some Zoom logistics. If you move your mouse to the bottom of the screen, you can access the mute and chat buttons. Next slide. And if you click on that chat tool, you can enter your name, discipline or organization, so we can have a record of your attendance. And after typing the information, make sure you press enter. Next slide. And of course, there is a mute button on the bottom left-hand corner as well. So please mute if you are not speaking, so that you don't get extraneous noise. Next slide. And in order to receive CMEs, you need to have registered and then complete an evaluation afterwards. We'll put these links into the chat box towards the end of the session. Just a note that we were unable to get the NASW CEs for today in time, so apologies for that. Hopefully we'll have it for next time. Next slide. Okay, and so just introductions. I'm not sure if they are here actually. I didn't see them. Yeah, usually we have our team of nurse practitioners, social work, and pharmacy, but I know that they got tied up today. So it'll just be Dr. Liu and myself today. Okay, and then.
I'm here.
Oh, you're here.
Chad from pharmacy.
Looking all up and down this participant list. I couldn't find you. Okay, wonderful.
Thank you. It's a long list. No worries.
No, thank you for joining us. Sarah, are you there? Or did I miss you as well? Okay. All right. Anyway, great. Okay, so anyway, finally, I'd like to introduce you to Dr. Brett Liu. He'll be talking to us about depression and dementia screening during COVID. He is an associate professor and a geriatric psychiatrist at the John A. Burns School of Medicine. We're so honored he took time out of his extremely busy schedule. We really appreciate you joining, being able to share with us and answer questions that we may have. Just want to mention that Dr. Brett Liu has disclosed he has not had any relationships with commercial supporters that could be perceived as a conflict of interest in the context of this presentation. Okay, so Dr. Liu, you can go ahead and share your screen. Thank you very much.
Okay. All right, share. Okay, can you see okay now?
Yep.
Okay, so I'm gonna get started. Okay, hi, welcome everybody. So what we're gonna be doing today is talking about COVID-related considerations for depression and dementia evaluation online. And I am going to find a way to advance my screen if I can. There we go. Um, okay, so my talk is going to be pretty short, just 4 small parts. We'll be talking about the impacts of COVID to mental health, especially in a sort of an age group specific manner. There's a lot of interesting data that's coming out. There's going to be a lot more data coming out, but it's already interesting, with less than a year of empiric research. And then we'll be going over how, what are some of the tips that we can share with you on assessing older patients via telemedicine. We have done lots and lots of telemedicine visits ever since COVID started. And then, we'll talk about, these 2 issues in the context of, how to go about evaluating and reporting depression, as well as dementia. Okay, so COVID, worldwide pandemic. What is it? What's the impact on mental health in general? So this is a very nice review, basically collating all the studies from all over the world to find sort of the consistent trends. And what has been shown so far is, those people with COVID do experience, higher incidence or higher symptoms of PTSD-like symptoms, post-traumatic stress disorders, as high as 90%, and as well as depression, among COVID survivors. And also, even without COVID, being afflicted with COVID, those with, pre-existing mental illness, they do experience increased frequency and intensity of their psychiatric symptoms. And in terms of, all of us, who are, healthcare providers, that we are also subjected to higher rates of depression, stress, anxiety, insomnia, during this COVID pandemic. And as much so for those caregivers that they're not unpaid. I mean, they are unpaid. And risk factors for, having increased behavioral health issues or concerns include, female gender, people that have poor health already, and also people who have relatives that have already been affected by COVID. Okay. So since we're going to be talking about depression as one of the 2 target symptoms today, there are some differences in terms of age, in terms of how different age groups present depression. This is independent of COVID. So as we get older, more older people or adults and older people will experience higher rates of depression as opposed to people that are younger or adolescents, in a way that is predominantly female in a 2-to-1 ratio. And we'll talk about later how older people may manifest their depressive symptoms a little bit differently from others. They're not, a lot of them, they cannot tell you, especially when they have dementia, they cannot tell you that, I'm depressed. So these are some of the sort of telltale signs that we'll go over later. Okay. So given high or higher rates of depression, given older people are, much more susceptible to COVID-related medical complications, and as well as social isolation, we would expect that older people are going to be showing the highest increase of mental health burden because of COVID. Well, this is kind of a little bit interesting. This is not what the data has shown thus far. But again, the caveat is, we're still sort of kind of relatively early in this COVID pandemic, so the data may change. But so far, the older groups are actually much more resilient less susceptible to these COVID-related increase in mental health symptoms. And the word that's been used is that the older you are, the more resilient that you are to these various stressors. And I'll show you the specific data for this. So this is, this phenomenon is not just in the United States, it's seen worldwide, in Europe as well. But coming back to the United States, so this is a CDC report that pretty much survey the prevalence of different types of disorders in mental health, anxiety, depression, substance abuse, or having considered suicidal thoughts. And whereas they don't really see a difference, so the way you want to read it is, so among female participants, 26% reported, anxiety disorder versus 24% for male. So there isn't really a gender-specific difference in terms of dealing with or having emerging COVID-related symptoms. But if you look at the age groups, there is a huge difference with the older the participants are, the more protected they are from COVID-related mental health symptoms. So this is kind of surprising, and a lot of people had offered to give explanations about why this could be the case. And this is, what's been shown so far was that, another way to say this, we're older people are kind of like scar tissues. They know how to deal with variety of life stressors, including COVID. And the word for that is resilient, that the same degree of trauma affects older people a lot less than it would affect with younger people. And also older people, they actually follow these COVID guidelines much more strictly. They are more likely to wear their personal protective device, more likely to avoid outings. And in terms of relationships, older people, they, even though they don't have a lot of, parties, these, different groups of social circles, the fact that they value quality, which is a few meaningful relationship, which is a lot less affected by COVID, over quantity, which is what young people like to do. They always compare with one another about how many, YouTube or Instagram followers they have. So the fact that they value quality over quantity in social interaction, that also increases protection for older people from COVID-related mental health consequences. So I mean, it doesn't mean that we're not going to not worried about the older people too much, because they are still very, very vulnerable to medical complications and social isolation. So and also the fact that it is harder for all of us to have physical visits with their physicians, older people are actually going to be at higher risk for able to sustain regular visits with their providers. So we're going to go into how to go about what are the challenges of doing telemedicine with older patients. Okay, so this is actually a study that came out. There's many nice studies coming out about COVID. So assessing to what extent are these older people in general in the United States prepared to do telemedicine. So the estimate so far is there are going to be about 13 million older people that's older than 65 years old. Among that are going to be unprepared for any kind of video visits. So, and this accounts for 38%. So basically 38% of all the US adults older than 65 are not able to have a consistent means of effecting a video visit with their provider. And even if they had social support, which is defined as living with one or two other adults or living with their child, there's still a very high percentage, a third of them still could not do video visits reliably. Whereas with telephone visits, I'm a little bit surprised with this, that even just with telephone, not a smartphone, the regular phone, a fifth of them still had trouble initiating or able to maintain some kind of effective telephone consults with their physician, even with some additional help. And again, and it's common sense would tell us, yeah, a lot of this is due to their lack of experience with technology, and worsened by the fact that they have a lot of hearing or visual impairment, making video visits much harder to do. And even worse so is for those people that are 85 years or older, the number of people, the percentage of people not able to do telemedicine jumped from 38% to 72%. Okay, so even when we're able to finally do a lot of caregiver education or family education on how to go about doing telemedicine, there are still some tips that I want to share with you. So we're able to do it, so you're all able to do it much more efficiently and effectively. So before any kind of telemedicine interview, we have worked with so many apps, I lose track. I bet we have done maybe 10 or 12 apps, if not more. I would highly encourage providers to choose an app that does not require any downloads. So for example, if you ask them to download this app, and then before the interview, more than half of the older people, unless you have like a really good IT support, will not know exactly what to do with the downloads. So web-based programs like Zoom, for example, I have no disclosure to make. I don't own any Zoom stocks or any, anyway. So whereas Zoom is web-based, they can just go to zoom.com and they can start right there. I think for example, for those of you working at Queens, we had trying to roll out a program known as WebEx. The problem with the WebEx is it does require the patients or their caregivers to download some sort of WebEx extension at their end. And 80% of the time when we couldn't get the telemedicine going, it's because they did not know what to do with the downloads. And also we still struggle. I would say routinely we're still spending about half of the time of allowed 30 minutes or 40 minutes on working on technical issues, just because that's the nature of the beast. But hopefully one of these days we'll have more and more apps that are much more consumer user friendly. So once you're able to get connected, yeah, you want to make sure, especially with people with dementia, that there are no other distractions. If there are a lot of people hanging about, there's something else going on, they're not going to pay attention to exactly what's going on the screen. And for people that may be a little bit shy or guarded about their symptom, suicidality, signs of depression, or people with dementia arguing about their paranoia. You don't want to get into an argument, between a patient and the caregivers about exactly, who stole the money. So you want to make sure that there's some sort of privacy so that each party, relevant party, can talk in turn. So example with person with dementia, maybe 5 or 6 minutes after the into the interview, I would ask the caregiver to take the patient aside. I would say, well, hey, I'll see you next time, but I need to go over some paperwork or some medications with whoever is taking care of you, and then allowing the caregiver, the family members, to give their side of the story. You do not want to have conflicting information all going on at the same time, or an argument. And making sure the camera angle, lighting is all appropriate. Okay. So this is probably one of the biggest challenges, is a lot of older people, they cannot hear well. So what can you do? And this is what I was asking about Dr. Ida earlier, is, make sure the chat function is working. You'd be surprised how many older people, when they cannot hear, they have some levels of dementia, that they're still able to read. And so using that chat function sometimes can help to communicate versus, you screaming into the microphone and they still cannot hear you. Sometimes using headphone, kind of like what I'm doing right now, really helps to cut down the background noise. It can enhance the hearing at the other end. And then there are times that people with dementia, they simply cannot understand the concept of talking to somebody via video, or they cannot hear you at all. And I find this is very helpful, just to ask a caregiver, can you pretend that you're Dr. Liu, or just pretend that you're the doctor? And then you can just kind of whisper softly the question that you wanted to ask, and then have the caregivers say those questions verbatim to the patient. And that works out pretty well in those cases. And you don't want the caregiver to say, well, Dr. Liu wants to know this, Dr. Liu say he's wondering. I was like, no, just make it verbatim. How is your pain? And do you have any pain? And then the patient, and then the caregiver will say, well, do you have any pain? So word for word. Okay. Let me see. Okay. So let's go over how do we screen for depression and dementia, in the context of telemedicine. It's not going to be that much different, but let's just kind of go over the general considerations. So a lot of older people, especially with dementia, they're not going to tell you outright that, hey, I'm depressed, do something. You do need to be aware of some of the more subtle signs of depression in older folks. This is what we were talking about earlier about age-specific presentation of dementia of depression. So depression tends to be associated in older people with greater levels of somatic complaints. Usually in headaches, belly aches, kind of like pain of unknown origin. And this can be a manifestation of depression as long as there's nothing physically wrong with them. And some other signs of depression is that they have very poor attention, they avoid eye contact, making very little effort to engage. And then another dimension very important in how older people express their depression is through being irritability and anger. That for the last, if you feel somebody is that for the last few weeks or so becoming increasingly irritable, rejecting help, gets angry when you're trying to help, that also could be a signs of depression. And these are questions that that could be easily asked by physicians or providers, and questions that you can easily educate their family members and caregivers on what to routinely screen for, after the telemedicine session. And in terms of overlap, a lot of people with dementia do develop depression, and conversely, not everybody with dementia will have depression, because that's not the case. So I would say about 20% of, and this is the population that really cannot tell you that I'm depressed. So about 20% of people with Alzheimer's dementia would suffer from depression, higher rates for people with vascular dementia related to strokes, and half, if not more, in people with Parkinson's disease dementia. So again, the cardinal signs without self-report are irritability, and rejection sensitivity, poor eye contact, things that we had talked about already. And why is it important to really screen for depression, especially in cognitive impairment? Because this is one of the well-known risk factors for physical aggression, higher risk of death, and faster memory decline if the depression is not treated effectively among those with dementia. Okay, so so one of my tasks today is to share with you some of the easy, elegant screening instruments, objective instruments for measuring depression in older adults. So I can think of three that I think any primary care physicians, ancillary providers, or even caregivers can help to do, can do on their own at home or online if needed. So there's so the three are the PHQ-9, which is used for a larger sample of population from different age groups, but specifically for older individuals. I like to do the geriatric depression scale, which is a 15-item yes or no question. I'll show you some examples of that. And for those people with depression, those people with dementia, there's a scale that can be used, has been validated to measure depression, and this is a Cornell scale for depression in dementia, more appropriate for people with moderate or severe dementia. Okay, so this is an example. Not example. This is the PHQ-9. As you can see, you just kind of again, all these questions are supposed to be not self-administered. So either the physician would have to give it, or the test you have to give it yourself, or with a caregiver. So in this case, go back to PHQ-9. So you would just read these questions and pick one of these numbers. You total the scores, and the scores would tell you the worst, the depression, and with some guidelines about when should you consider clinical evaluation. So mild depression, 5 to 9, would probably be a threshold that you may want to consider getting a provider to be involved. So again, but this is for the more general population. This is the more specific for older people, geriatric depression scale. 15 yes or no questions to be read out loud. This is not designed for the patient to score on their own. It's just the way the testing instruments are done. You want to do it exactly the way it was conceived. To be read out loud to the patient, and a score of, so basically, any of these bolded answers is consistent with depression and will get 1 point. And if you have 5 more answers in the bolded area, that would be consistent with depression. So I use this scale a lot, actually excessively, in our geriatric psychiatry clinic, not only to screen for baseline depression, as well as for tracking a longitudinal response to any kind of antidepressant treatment or psychotherapy we do. And however, for those people with severe or moderate or severe dementia, this is not valid. So if you have somebody with somebody with severe dementia, and you have a social worker saying that their GDS is 10 out of 15, yeah, I would have second thoughts about how valid that is. So that takes us to Cornell scale for depression and dementia. So this is where you don't really ask you don't ask the patient directly these questions. You do it together with a caregiver. So you would talk to the caregiver and rate their anxiety, sadness. It can be kind of subjective, but that's one of the best instruments we have. And then you would score from 0 to 2. If there's no information at all, you would just be unable to evaluate. 2 would be the most severe. So once you go through all these, it takes about 15 minutes to do, or less, about 10 or 15 minutes to do. Even less if you're familiar with with the instrument. And a score of 12 or greater would be consistent with depression. Okay, all right. So now we had talked about signs of depression in older folks, what questions to ask, and a standard screening instrument that you could do on your own. So what if the screening comes back as positive? Well, it depends on the severity. For anybody with identified to have depression, you want to offer support, monitoring, checking on them more frequently, video visits, phone visits if possible during COVID. And what is very important, and I've seen a lot of fair families and caregivers not do this, is you want to validate their concerns and feelings, and you want to listen to them empathically. If they're feeling this way, please do not tell them that that's not valid, that you just get over it. And I hear that too many times, because when you do that, it's just going to shut them up. And they'll internalize their stress, and worse, then you'll have a worse outcome. And also, don't try to be trying to rescue superficially, which is, well, I know how you feel, and you know what their response is. How dare you say you know how I feel, and that would lead to them shutting down again and not wanting to communicate. So just empathic listening is going to be very important. And if you feel like the screening instruments or the answers to your typical questions are starting to raise concerns, you do want to contact primary care physicians or behavioral health providers to see what could be done. Because of COVID, a lot of therapy therapists have shut down their offices and have resorted to online therapy only. So one website that I usually tell the patients is psychologytoday.com. I'm not affiliated with that for Hawaii. Again, psychologytoday.com. And you can find a list of therapists, with your insurance and your specific mental health conditions. And for safety concerns, there is a crisis hotline that is still operating 24/7. These are the numbers that could be called on Oahu and the neighbor islands as well. Okay, so let's go to the last part of our talk, which is dementia. So basically, when we screen for memory decline, we're actually looking at two stages or three stages. Normal versus intermediate, which is what we call mild cognitive impairment. But if any of you subscribe to the new DSM-5 or psychiatric definition, it is known as a minor neurocognitive disorder, which is pretty much synonymous as MCI. So that's sort of the intermediate stage, and then the last stage will be dementia. So what is different between MCI and dementia? So in people with mild cognitive impairment, yeah, they have some cognitive decline. On any kind of standardized testing, they'll probably score 2 standard deviations below their education or age-adjusted norms, but they have not yet experienced loss of activities of daily living. So and this is a picture that shows different types of ADLs. So these are sort of, there's a more basic type of ADLs, and these are the instrumental ADLs. So people that with MCI, they may score poorly on their memory testing, but they're still able to do most of these. Whereas in dementia, clinically, it can be defined as a combination of cognitive decline as well as the loss of these ADLs, and starting with the loss of instrumental ADLs. So how do we go about asking questions to see if somebody you care about maybe at the stages of progressing into MCI or dementia? Well, before you do that, you want to make sure there's not any underlying depression or any new medications. There's a phenomenon known as pseudo dementia. So anybody with pretty significant depression, their memory will be impaired because, as we talked about earlier, they don't pay much attention to what you're saying, what's going on, and that translates to sort of apparent loss of memory. So if there is any depression, you want to treat that aggressively because that is much more reversible versus trying to reverse a cognitive decline. A lot of medications can have contribute to a memory decline or confusion. So you want to explore that first. And in terms of memory loss, the memory loss, the way that Alzheimer's or dementia progresses is that there's a loss of recent memory first, and whatever they did when they're little, that's remote memory, and those are the last to go. So don't take any comfort if you're concerned about somebody who may be experiencing memory decline, but the family will tell you that, well, they can remember so-and-so's birthday, they know exactly all their grade school teachers. That's not any consolation at all. That's remote memory. But if you ask them about, well, what did you eat for breakfast today, or where did you go yesterday? If they couldn't tell you, that's signs of concern. Okay, and in terms of asking about whether they have any loss of ADLs or not, so I would ask questions about whether they were able to do this or not. So if they're not able to cook anymore because they leave the stove on, or they're making errors on writing their checks, not knowing how to use remotes on TV or telephones. So these are signs that they are starting to experience this loss of ADLs. So these are previously acquired skills that you're not able to do anymore, and not because of physical disability. So, and a typical question I would ask the caregivers is, or families are, are there things that they're able to do before and they couldn't do anymore? And it's not because they couldn't do it physically, or so like not knowing which key to go into which lock, or not knowing how to, or going to a new gas station and not knowing exactly what to do, or not able to cook, this recipe, or not able to sew. So these are all the things that would signify the beginning stages of those ADLs. Okay. So there's still some easy instruments that you may want to consider if you want to make these if you want to do it online. And these are some of the things that we are trying to do online for conducting a memory testing. So I just want to share with you 4 possibilities quickly. We have done, and these are mini-cog, mini-mental, MoCA, Montreal, not Montreal, and slums. So I was just going to go over them one at a time. But before then, remember we talked about the 2 stages of cognitive decline, MCI versus dementia. So actually, okay. So why do we care about whether the stage that we have somebody who is staged to be at MCI versus somebody who is dementia? No, we do worry a lot. It's very important because when a person is progressing into MCI or is or having MCI, this is where you can still address a lot of reversible risk factors for cognitive decline, much more aggressively with a much bigger impact. And we'll go over these risk factors later. Whereas if you don't address them and they progress into dementia, then the impacts and the EO is going to be a lot lower when you try to address these reversible risk factors for cognitive decline. Okay, so mini-cog and mini-mental are pretty good in differentiating people with dementia versus no dementia, which also could include people with MCI. But if you really care about detecting memory decline early, somebody with MCI, MoCA and slums, which are harder tests for patients to do, will be more appropriate. I tend not to use MoCA anymore because I would say about a month ago, they're starting to charge for, I think like $200 to be certified to be able to use it, where slums is public domain. Okay, so mini-cog is the one that we do a lot in our clinic. It takes just a few minutes. Basically, it's a 2-item exam. It's a 3-word recall and a clock draw. So as long as you have somebody helping with pens, papers and pencils on the other at the other end, when you do a telemedicine, it can be easily done. Just ask them to recall, give them 3 words, have them draw the clock 10 after 11. And you would score here point wise, and you would and eventually eventually you will want to score as possible impairment or no impairment, which is unlikely dementia. So this scoring system has been shown by studies to be more specific and more sensitive than primary care physicians in predicting whether their patient has dementia or not. And it's also very robust to people not speaking English as their first language. As long as can understand simple instructions, 3 common words in English, and clock is universal. So that this has been shown to have very, very valid in non-native English speakers. So mini-mental is very similar to mini-cog. Is good for assessing dementia, but I don't tend to use it a lot now because it takes longer versus just mini-cog. Every minute is valuable for providers, especially if you spend like 10 minutes on troubleshooting with their your app. Okay. In MoCA, I don't like, we haven't done a MoCA online yet because of the certain, it takes much longer than slums, which I'll talk about later. There's a fee now that you have to, pay to be able to use it. And there's some items in here, it just makes it hard to do online. Like there's a test question where the patient must tap with his hand. So it just involves more camera angles to be repositioned. So we haven't been doing that. What we have done a few times is doing SLUMS, which is a St. Louis University mental status exam. For somebody that we suspect is having possible beginning stages of MCI, and it's public domain. So so this is our preferred screening instrument. Okay. All right. So say if they're positive, you're concerned about memory decline. What are some of the options in COVID? Well, you want to treat any underlying depression as even more aggressively. And this is especially people with MCI. This is the best time than ever to start looking at reversible risk factors. For medical risk factors would include working with your PCPs on making sure that your blood pressure, cholesterol, and your glucose levels are all under good control, because these have a much bigger impact in slowing down memory decline versus any dementia medication you hear on TV. And lifestyle changes, physical exercise, 30 minutes at least per time, at least 3 times a week. Psychosocial routines, basically you want to maintain that sensory input. And for those people with more severe memory decline, you want to start talk to the families about preparing for the next stage. Talk to family about avoiding confrontation unless it's they're doing something dangerous. Very important at this time to make sure that surrogacy planning is finalized, and also start to be aware of different resources for dementia like Alzheimer's. And also the state, the city of Honolulu has a senior handbook that talks about all the resources like adult day programs. I think some of them are starting to open up now during COVID. Okay, and so these are just some of the tips about how to avoid, we talk, avoid confrontation, validate their feelings. And this is my last slide. So what can we do? In COVID, there's no adult day programs, there's no senior classes, cannot go to the senior centers anymore. Well, there's still a few things that we all could do to help to maintain some kind of sensory stimulation, which is important to prevent that accelerated cognitive decline. So these are some of these things that have been proposed and studied. Probably the most effective so far among plants, animals, massage, aromatherapy is music. So you can play music anywhere, even in their rooms. And in this case, probably not classical music or modern music that they're not used to. What seems to be the most effective would be music that they were listening to when they were like teenagers or early 20s, music that is more familiar to them, and that seems to be the most effective in soothing these patients with dementia and preventing any kind of agitation. Okay, all right, that comes to my talk. So I think we still have a little bit of time for case discussions or any other questions.
Great. Thank you so much. That was a really fantastic overview, and really covered a lot of ground very, very quickly. And so I'm just thank you very much. If we could just unshare the screen, then we can see everybody else again. And then I just want to open that up to see if people have thoughts and comments. I know there are a lot of providers out there and have had challenges to some degree with this doing the screening and helping patients via telemed. And so I just wanted to open it up for that. I know there was a little thread here going on here about Zoom not requiring a download, but I think that was sort of resolved a little bit here, saying that you actually, if you use a computer that's hooked up to a landline that's not Wi-Fi, that's the most reliable way without actually having to download an app. But you know what, that itself comes with a lot of problems. I think computers in and of themselves are more complicated to use than iPads, and there's a whole host of technical issues. So it's not necessarily an easy thing. I think reserving time and having somebody to help is probably the best way. Let's see, there's another question here. Any study yet on the impact of social isolation on cognitive decline?
I cannot cite you a specific study, But theoretically, there's a lot of studies showing that any kind of decreased sensory input will hasten cognitive decline. So you assume that any kind of social isolation would be a part of sensory decline, and I would expect that would not be a protective factor for somebody who is having memory problems. And there actually studies showing that social isolation is predictive of somebody with higher rates of mental illness, and that's been shown even recently in COVID. I just saw a study on that. Yeah.
Mm. Yeah, it's important to be mindful of. Anybody else have any challenges, particularly with doing, I see some primary care doctors out there that you've encountered doing these depression or dementia evals via telemed. Any pros here or challenges?
There is a question in the chat about
Yeah.
the mini cog X past X time. Sometimes that's confusing to people with English as a second language.
Oh yeah, so I think on the MiniCog, if I remember, the exact instructions are 10 minutes past 11. You know, I'm okay I'm okay saying 11:10. I mean, the whole point is to be able to see them to put the long and the short arms at the right numbers. Yeah, so I'm okay with that. So I mean, that would be maybe one exception that I would not, administer the test verbatim. I would be able to, I'm okay saying 10 11, 10 11 10. Yeah, versus 10 after 11. Yeah, or 10 past 11. Yeah. So I think that's a minor modification. It shouldn't affect the validity of the test much. Yeah, because you really want to make sure they understand what you're trying to get them to do. That is much more important than following following the instructions verbatim.
Yeah. Oh, and I just want to say thanks, Jody, for the reminder here. Yeah, so Honolulu Heart Study actually has some research on social isolation and cognitive decline. So there's that Dr. Misaki has shared about in previous. There is some evidence for that. Okay. Oh, so Dr. Hitasugi Levesque had trouble finding slums for a lot of Asian languages like Tagalog. Do you just do English with one interpreter? With an interpreter?
Yeah, that's a great question. It's very tricky, and we don't do it. We don't try to have an interpreter do a slums with somebody who doesn't have enough of a command of English language. I would avoid doing that. So say if I have if I have a Korean speaking person and I don't have a Korean slums version, I may just do a mini cog instead, unless that Korean person doesn't speak any English at all. But usually they do. We can do a mini cog. And even if they don't screen as somebody with dementia, we could have a pretty good suspicion that they may be MCI. And even if they're pre-MCI, that would be a good time for us to go over all the reversible risk factors, like, working, controlling your blood pressure, cholesterol, and go through all the education about lifestyle changes. So all that could be done without having a slums test that is in their native language.
Yeah, I had a question. I was wondering about, if there are other non-English, there's limited screening tools. I mean, do you use any of these caregiver screening tools at all?
You mean like a caregiver conducted screening? No, I'm not. Do you have something in mind? No, we don't.
No, like Alzheimer's Association, I think they have stuff like this, CS8 or something, or 88 or, those kinds of, they're not.
No, yeah. So we just kind of rely. Sometimes our residents will find like slums or even mocha in a different language. then we will use those. But otherwise, if we don't, yeah, we kind of resort back to Minicog.
Okay.
And we actually have used Minicog very successfully, and it's been very useful in assessing, people that don't speak English well.
Yeah, I think so. And it's simpler too. Marcus Pang, yeah, addressing isolation. There are some day programs open now, such as St. Francis, the Furukawa's Age Perfection in Malama, and I think there are a number of other adult day programs out there now as well. And they're trying to do their social distancing and limiting the number of clients and all that sort of stuff. So that there are some available now. And thank you for your links. Central Union, yes, is another one.
Yes, right, and social isolation. We see it. I mean, the effects of social isolation of COVID, we see it in our patients. For example, I just had a case yesterday where they're not sleeping at all, and they're screaming up all night, wanting to go to the bathroom. This is a person with dementia, and we found out that ever since this person has not been able to go to a day program because of COVID, this person spent the whole day half asleep because there's no activities for them. So when nighttime comes around, this person wasn't ready to go to bed because he or she got enough rest. So this is one of the horrible outcomes of not having their psychosocial routines, especially through an adult day program. And I'm so very glad that more programs are being opened up again.
Great, yeah, I see all those. So not all those new other programs open. Go Home and Hale Haoli. Yeah. Anybody else seeing more depression in your patients?
Hi, Joanne. I'll share. Hi, Dr. Liu.
Hi.
This is Mahe Lam. I'm practicing primary care right now. I have an elderly patient, 80 plus years old with known depression on an SSRI, and she was having a lot of fatigue. No other symptoms, really no cold symptoms, no upper respiratory symptoms at all, just fatigue. And we did an extensive workup. I thought a component of it could have been her depression in the setting of withdrawal of physical activity, socialization. Ended up, I tested her, she had COVID. Oh. And that may have been asymptomatic presentation or the way that she manifested COVID, but she was just having a lot of fatigue compared to usual. So it's a difficult situation because with this patient, because of her COVID diagnosis, she's already done with her home isolation period. But the family, they just had this real stigma against her. She's living with her son and wife and their 2 children who are teenagers, but they were just so fearful of the COVID and spreading the COVID to the children. And it just had to be a lot of counseling and education to this family to share with them that it is a serious diagnosis. Thankfully, she didn't have serious COVID resulting in hospitalization or anything like that, but it's really the elderly and decompromised population that you have to be worried about catching the COVID and suffering severe COVID. Understand the concern for the children catching it, but based on the studies, they're not the population that winds up getting as severe complications as do the elderly. So what they had done is they actually put the patient back in her personal apartment. I guess they have 2 homes. There's the family home where they all live together, and they had still the patient's own personal apartment. So she was kind of isolated there during this whole time and beyond. Even though she was done with her isolation period, the family's still keeping her isolated over there because they're scared that, you don't retest for COVID to prove that they're done, that they're no longer infectious. You just go by time and symptoms. So I tried to explain to them that you can still test positive months later, even though they're no longer infectious. But if they have completed their time, they're not having any symptoms, then they could be considered safe to come back home. And they're just sitting there and waiting and saying, why don't we just wait till 3 months have passed then, and then we can bring her back home. And it's just difficult, just trying to reinforce and counsel the family that it's really during this time that our elderly patients need that support from their family, just being together with them and not having to feel dirty like they have this diagnosis. So I just wanted to share that and see if you had any pearls for
well,
that.
yeah, that means that's, yeah, I feel so bad. I hope they're able to, initiate some kind of telemedicine visit, which may be hard for her if she's living by herself and trying to navigate how to do a video visit with the family. And yeah, it's great. You're doing a lot of education with the family members regarding realistic risks. And what you had talked about, sort of segue to what I mentioned earlier was that people, those people living with COVID positive patients or ex-COVID patients, they're at much, much higher risk for having behavioral symptoms themselves, which in this case would apply to your family. So a lot of times when they may be stressed out more than ever, maybe some, underlying depression or anxiety, all, related to living with her, maybe those have to be, you may want to consider looking at that too, to lessen their burnout, because one of the consequences for burnout or for any kind of stress living with COVID patients is that they're going to lash out and they're going to be irritable. They're going to find ways to do things that they don't usually would do. In this case, asking the patient to leave.
Wow.
But yeah, just allow education, reassurance. Yeah, it seems like you're doing all that.
Thank you.
And what I learned too was that, yeah, I mean, somebody who is fatigued these days, in addition to what we usually think about medically plus depression, now we got to start thinking about, well, maybe this is the first sign of a COVID infection. Yeah.
Yeah, no, that's the reminder, right? Supposedly has some neuropsych effects as well. And so put that on the differential. Yeah, thanks. All right. So, yeah. Any other last comments? Because we are at the top of the hour. Yeah. Okay. So thank you for everybody for joining us. For CME credits, you have to go on the website. I think that we have another link that I think Michaela posted a little bit earlier in the chat box to do the online evaluation and indicate the type of CME that you would like. And then anyway, any of your comments and recommendations for different topics would be really helpful. So please put that in there, and please join us next month. January 13th is our next session, and our topic will be falls assessment and prevention during COVID, and we'll have physical therapy and case managers and all kinds of folks joining us to help us keep our older adults from falling more. Thank you so much, everybody. Thank you so much, Dr. Liu.
You're welcome.
Excellent.